So, Assalamu alaikum and a very good morning to all of you. It's my nice pleasure encountering you through this Google Classroom, but it's good to continue our learning phase. And the topic assigned to me today was acute glomerulonephritis, and inshallah, I'll try to cover the important aspects of the topic with you. So, I'll start my presentation with a 10 years old girl who was referred to us with a 5 days history of increasing facial edema and a right loin pain. Other referrals which were given were a 2 days history of decreased urine output. She was hypertensive at the time of presentation and her blood pressures were above 99 centile with a dark or cola colored urine. As you can appreciate, so was referred to us. So according to these presentations of this girl, we classified the child as having typical features of acute nephritic syndrome, which were characterized in her case by acute renal dysfunction, which was characterized by oliguria. She was having hematuria in the form of a cola colored urine. She was hypertensive and edematous. So the differential diagnosis of a patient who comes with this nephritic syndrome, which is generally classified by pathologies in the glomerular inflammation. It can be primary or secondary due to other infective or autoimmune diseases. We are familiar with the commonest infective etiology of poststreptococcal and autoimmune disease like lupus. I'll be discussing with you one by one. So her investigations were done. The positive finding on her investigations was a decreased GFR in the form of a increased serum creatinine levels. She was hyperkalemic. Her hematology was normal. So we proceeded further. So this was the typical presentation, the gross presentation of her urine. This was a normal looking urine and she had this very dark or cola colored urine, which is of a bookish picture. So as we can appreciate, and the urine reporting turned to be a proteinuria, which was a heavy proteinuria. She was having hematuria, heavy hematuria, and the dysmorphic RBCs, which were characterizing the glomerular involvement. Because any cases in which we get dysmorphic RBCs, then the hematuria is considered to be of the glomerular origin. So what further investigation would you like to perform? So giving her presentations of acute renal failure with active urine sediment, we always call the active urine sediment in which we have hematuria, proteinuria, RBCs cast. So a primary or a secondary cause of glomerulonephritis should be entertained. So the commonest which comes in everybody's mind is a post-infective etiology, and among the infections, the beta hemolytic streptococci are considered the most commonest culprit. You can perform the throat swabs to quantify the streptolysin O titers and anti-dsDNA antibodies. So the serological markers indicating the presence of streptococcal infection could be done. Other entities in which we can get a glomerulonephritis like picture are the SLEs and associated with it all the serology which is needed. I'll be discussing them in detail. You can have vasculitis which can present entities of good pasture syndrome in which we have renopulmonary involvement because of the anti-GBM antibodies. You have low C3 entities like cryoglobulinemia, and you have entities of mesenteric proliferative glomerulonephritis in which you have low complement levels. So this is a big picture of the entities which can give rise to acute glomerulonephritis. So coming back to her case, ultrasound is done, and ultrasound is very important to be done in all cases of the patients who present with acute kidney injury. So the ultrasound of this girl showed two normal sized kidneys with no hydronephrosis or any obvious abnormality. The serum complements were done which show a low C3 levels and borderline low C4. So this turned to be a low complement entity. Other immunological entities were negative, that we didn't got the serological evidence for lupus or anti-GBM. So the entities or the differential when we get a low complement in a patient of acute glomerulonephritis, as you can appreciate, we can have post-streptococcal, we can have entities like bacterial endocarditis and shunt nephritis. Membranoproliferatives have low C3 levels, lupus have low C3 levels, while on the contrary, those with normal components are the entities of IgA nephropathy, HSP nephritis, all the vasculitis which are associated with ANCA, and the entity of mesangial proliferative. So this mesangial proliferative is different from the membranoproliferative glomerulonephritis. So what happened to this girl? Her low complements were followed by an ASO titer which were reported to be 400, which was more than her normal limits, and other serology indicating the streptococcal entity were positive. So the final diagnosis of poststreptococcal glomerulonephritis was made. A few words which we'll be discussing further. So same child workup yield low complement level. So if you have a low complement level, but on the contrary the patient did not show a post streptococcal evidence, then what shall we consider next? We sent her, as she was a girl of 10 years old, we sent her ANAs and anti-double stranded DNA, which turned out to be positive, and so the diagnosis of lupus nephritis was confirmed. So anybody who has a AGN-like picture with low complement levels with normal ASO titers, on the contrary, a positive serology for lupus, then you consider the diagnosis of lupus nephritis. So if we consider the same patient who presented with acute glomerulonephritis, just to explain you further more entities, if she develops a further reduction in her urine output, that is deteriorating renal functions, and the serum creatinine which was gradually rising, and the pressures which were uncontrolled, so the renal failure was progressing considering her this picture. So this impression gives us the clinical entity of rapidly progressive glomerulonephritis. So RPGN is a clinical syndrome like acute glomerulonephritis. It is characterized by acute nephritic picture along with the rapidly deteriorating renal functions. So RPGN again can be caused by all the entities which results in acute glomerulonephritis. So ultrasound guided biopsy is very much needed in such patients who present with normal sized kidneys with acute renal dysfunction and a rapidly rising along with the underlying evidence of hematuria and proteinuria. This slide just gives you a highlight of the various pathologies which we can entertain. I'll be explaining further to them. So just to recapture that acute nephritic syndrome which presents, as we have discussed, with hematuria, hypertension, RBCs cast with some degree of sterile pyuria, that is you get WBCs but they are non-infective. You can have mild to moderate or a severe proteinuria and inflammation which eventually leads to uremic syndromes, and salt and water retention leading to all the features of acute kidney injury. And the rapidly progressive glomerulonephritis, as we discussed, is again a clinical syndrome, nephritis plus the rapid loss of renal functions within days to weeks. And histopathology is done. If it is done, it's consistent with crescents in more than 50% gloms, indicating severe glomerular injury. Then you label it as crescentic glomerulonephritis if you get crescents which are more than 50%. So RPGN is a renal emergency, to emphasize, which if untreated it rapidly leads to the irreversible loss of the renal functions. So this inflammation needs to be halted by immunosuppressive therapies. So causes of the RPGN, as I have said, all those entities which can lead to acute GN can further worsen to give rise to RPGN. So all the anti-GBMs, all your MPGNs, your lupus or a post-infective, usually post-streptococcal nephritis do not present with this degree of the renal failure, or entities of your ANCA mediated vasculitis which can present with RPGN. So these were just a few words regarding RPGNs. Just would like you to review these crescents which are there. So the crescents are characteristic of the crescentic glomerulonephritis which are there in the Bowman's capsule. They are cellular and fibrocellular because of the damage to the glomerular endothelium. So the post-streptococcal, from where we started the case of our patient, you all are familiar. I'll just rapidly go through this. That 80% of the AGNs are because of post-infective. C3s are low. There is proliferation of the GN. You get it mostly after the upper respiratory tract infections or your skin infection with a variable duration. Those after a respiratory infection presents early. Those after skin manifestation, they present later. And the typical age are the schoolgoers patient. So this is the scenario of how the progress of the acute glomerular injury occurs and how it resolves. What is the natural course? So all the patients, you have a latent period when you get the infection, and then because it is post-streptococcal, and then you start getting the clinical manifestation. So edema is the first. You have gross hematuria, but they usually resolve, as you can appreciate, in first week to 10 days. There is hypertension, there is proteinuria. So the microscopic hematuria is the last, which can even take up to 1 year to resolve. The complement levels, usually if it is post-infective, they normalize within 10 to 12 weeks. That is 3 months. So this is the basic difference between the post-infective glomerulonephritis and other low complement entities, which I will be emphasizing, in which the complement level usually does not normalize after 12 weeks or the 3 months of your disease onset. So this is typical of the post-streptococcal picture, in which you get subepithelial humps, which are the characteristics of the post-streptococcal. Usually we don't need to do a renal biopsy in acute post-streptococcal glomerulonephritis. Investigation, as we have already gone through all your basic investigations, as we have done through the case. Treatment usually is conservative. We need to control their blood pressures through diuretics. We need to take care of the intakes and outputs, and rarely is needed a dialysis in this patient. The prognosis of the acute post-streptococcal glomerulonephritis is usually good. So coming to the next entity of the lupus nephritis, which can again present like acute glomerulonephritis, and the child can come to your clinic with entity of hematuria and cola colored urine. So I'll start my this topic with a case again of a 12 years old girl. She was diagnosed SLE 3 months back and was later referred to our nephrology OPD clinic with the complaints of pedal edema. And when we investigated, we did the urine TR, so it showed a proteinuria of 4 plus, and then a hematuria which was 15 to 20 RBCs per a high power field, and a proteinuria that was spot urinary protein to creatinine ratio, which was 4.5. So anything 2 or more than 2 is a heavy proteinuria. So this girl with a background of positive lupus had nephrotic range proteinuria, RBCs and WBCs, that is sterile pyuria. So impression, as we can appreciate, that it was acute nephritis with a nephrotic range proteinuria, and the most likely pathology is the lupus nephritis in the background of a positive SLE patient. Yes. So the next option of the investigation or the management plan is the renal biopsy, which was done in this patient, and we encountered a class 3 lupus nephritis in this patient. And then you have to proceed accordingly according to the classes of the lupus nephritis. I'll highlight just in a single slide to you. So on the contrary, if you have a patient with lupus and the urine DR turns to be a proteinuria of 4 plus, and there is very insignificant hematuria, only 2 or 3 RBCs. So this characteristic is the heavy proteinuria and a spot protein creatinine ratio of nephrotic range proteinuria. So this is a typical presentation like a nephrotic rather than nephritic syndrome. So in this case, the renal biopsy showed a class 5 lupus nephritis. So just to emphasize that the lupus can present like nephritic or nephrotic syndrome, and when the typical clinical presentation is that of a nephrotic syndrome, that usually the underlying pathology is a class 5 lupus nephritis. See, it's lupus nephritis, it's common, serious complication. It is mostly encountered in the children, and 80 to 85% of the lupus patient, they develop renal involvement. It's more common in Asians and Afro-Americans. So this is the spectrum of the renal manifestation in the lupus patients. So almost in the table, as you can see, 100% of the patient presents with proteinuria, but you can have variable degree of proteinuria. Around 50% of the patient have nephrotic syndrome like proteinuria, that is heavy proteinuria. Hematuria is mild. You can have microscopic hematuria in 80% of the patient, or you can have RBC cast. Gross is not very significant in case of the lupus patient. The point to emphasize is they can present with acute kidney injury or an RPGN like picture, as I've told you. 50 to 15% they are hypertensive, so we need to take care of their pressures also. So lupus nephritis, you'll be familiar with all those pathology of your fourth year behind the lupus nephritis. It's immune complex mediated, and results in the deposition of the immune complexes and the immune mediated injury to the renal glomerulus. So this picture shows the diagrammatic and the histopathology manifestations of the various classes. So this is the class 1, as the cartoon shows. This is a very normal looking gloms, but you have immune mediate immunofluorescence positive, and IMF is positive in all the classes of the lupus nephritis. It is characterized by IgG C3 and C1q deposits. But the morphology is different. In class 5, you have membranous nephropathy. In class 3 and 4, you have diffuse and focal and diffuse mesangial proliferative glomerulonephritis, while in class 1, the histopathology is normal. So the cartoon emphasizes that in class 5, you have membranous deposits, all these black dots, while in case of the class 3 and 4, you have mesangial proliferation and it gets entrapped into your GBM and endothelium, giving rise to a tram track appearance. So this again tables tells you the same classification which I have explained you on that diagram, all the class 1 to class 6. So the last one is the sclerosing type, the class 6 is the sclerosing lupus nephritis. So just one slide regarding treatment. It includes your induction and maintenance phase. You need not to remember this treatment protocols, just main headings. So it includes your immunosuppressives. You need to give adjuvant therapies like hydroxychloroquine. You need to manage their blood pressures, and you need to take, but there are emerging therapies also, which are rituximab and other anti-cytokine therapies. So I'll just skip this lupus nephritis. It involves all those it tells you the immunosuppressive and this MMF which is given in these patients. So this is the American College. It says you need to diagnose your patient, then you need to treat him with induction therapy with MMF or cyclophosphamide. You have to adjunct your patient with hydroxy pressure controls. You need to take care of your proteinuria with the help of AC inhibitors, and these guidelines are for the adults. So coming to another entity which can give rise to acute glomerulonephritis like picture, and the patient can come to your OPD. So this is a scenario of a 6-year-old boy who was brought to the OPD again with the features of nephritis syndrome, hypertensive, oliguria, basal Krebs, and past history was that 3 months back he was labeled as acute poststreptococcal glomerulonephritis on the basis of low complements and borderline ASOT levels. But this time when we examined the child and we investigated him, he was again having an active urine sediment in the form of RBCs, WBCs, and the complements were still low. So this is an entity of persistent low complement levels. Her lupus serology and the GBM serologies were negative. So in the context of this persistent low C3 beyond 12 weeks of the initial illness, you consider other entities of low complements, and the common which turned out in this patient was of that of a membranoproliferative glomerulonephritis, that is MPGN. So a few words about MPGN, membranoproliferative glomerulonephritis. It's also called the mesangiocapillary glomerulonephritis. Again, because of the mesangial enhancement and its invagination into the GBM, leading to the thickening and splitting of the GBM. It's immune mediated. You get the immune deposits in the mesangial proliferative disease and low complement levels. So it's basically divided on the histopathology findings into type 1, type 2 and type 3 MPGN. So the type 1 MPGN, it can be primary or idiopathic, it can be secondary because of the infections, or it can be a dense deposit disease in MPGN type 2. The MPGN type 2 is also called a dense deposit disease. It is usually primary or idiopathic. MPGN type 1 and type 3 are usually secondary, in which the infections or entities like autoimmune can be playing the role. And this table again emphasizes the MPGN type 1, type 2 and type 3, how the light microscopy and how the IMF and the EM shows. And I'll not emphasize more because you have gone through them in your pathology lectures. So this is the diagram or the cartoon which represents your mesangial proliferative glomerulonephritis. So these were the acute post-infective glomerulonephritis in which you had humps in your subepithelial humps. These are type 2 in which you get the deposits within the GBM. This is the type 1 in which you have mesangial proliferation which starts invaginating. Coming to the entity of IgA nephropathy, it is an immune complex mediated. It has variable spectrum of the histopathology changes. You can have mesangial proliferation only, you can have membranous pattern, but the pathognomic are the IgA deposits in the IgA nephropathy. They usually present with gross or microscopic hematuria, recurrent hematuria, and usually mostly followed by respiratory tract infection, the entity which you called as synpharyngitic. Rarely acute renal failure or rapidly progressive glomerulonephritis and a nephrotic range proteinuria can be there. So studies of the patients with IgA nephropathy support the use of AC inhibitors in patients with IgA nephropathy, and very rarely we need to use these immunosuppressive therapies. But yes, when they presents like RPGN, then you need to give steroids and cytotoxic agents. So another entity which resembles IgA nephropathy is a case of a 9 years old girl who was referred to OPD because of the petechial rashes on the legs, joint pain, and a fever which was not documented. She was euvolemic, not in renal failure, and non-blanching petechiae all over the extensor surface of the lower limbs. Her CBCs were normal, her renal functions were normal, and a urine DR which showed a proteinuria which was mild and a microscopic hematuria was documented. So considering her clinical presentation with microscopic hematuria, we made the diagnosis of HSP nephritis. So what is typical regarding henoch-schwannoline purpura? It's the most common vasculitis in children. A common renal manifestation is microscopic hematuria in 80% of the patient, and usually subnephrotic range proteinuria. It resolves in 1 to 3 months. And the typical biopsy resembles very much like IgA nephropathy, that you have IgA deposits. But the difference between HSP and IgA nephropathy is that in IgA nephropathy, you don't have clinical manifestations like these petechial rashes over your extensor surface, while in the extrarenal manifestations are typical in HSP. This algorithm just tells you the management of HSP nephritis. I'll just skip this one. Coming to the last entity of the ANCA mediated vasculitis. So we have the vessels involvement from the very small vessel vasculitis to the large vessel vasculitis. As you know from your basic pathology knowledge, we have Takayasu's and polyarthritis nodosas, but the commonest in which we have these are the small vessel vasculitis in children. So the ANCA vasculitis are the small vessel vasculitis in which the small vessels like arterioles, capillaries, and venules are involved, and they have NK positive, that is the antibodies against the anti-neutrophil cytoplasmic antibodies. The commonest type are of the anti-proteinase 3, anti-PR3, and anti-MPOs. So this slide, which is the last one among the NK vasculitis, so this is the point in which we have immune complex vasculitis, all the vessels in which can lead to acute nephritis. So large vessel vasculitis, medium vessels, they are rare. The small vessel vasculitis, yes, in which we have NCAS positive, and this is your immune complex vasculitis. And the commonest vasculitis among children is the HSP or the henoch-schwannoline purpura nephritis. So with this overview of the acute glomerulonephritis entity, which can be a presentation of the number of infective and non-infective entities and immune-mediated entities. To begin with, infective were the poststreptococcal commonest, immune-mediated were the lupus. You have mesangial proliferative or the mesangiocapillary glomerulonephritis. HSP nephritis can present like this, and IgA nephropathies, they can have manifestations of microscopic hematuria. So just to finish my talk and discussion on this topic is that we need to be alert considering the spectrum of the underlying pathologies which can give rise to acute glomerulonephritis. And I thank you all for your attendance and your attendance for this presentation. I'd be happy to respond to your queries. You can contact me. My number, my email there is with the IT team. So if there are any queries, you can just come back to me. And good luck and thank you all and stay safe.